I've got Lindsay here with GHP, and I don't think I gave it justice when I was talking about Opportunity Houston earlier, and I want to make sure everyone knows the impact this is really making to the area.
Yeah, so we're downstairs as well and upstairs, so and you've seen these. So we just launched an image campaign locally in June. It's Houston, the city with no limits. You may have seen it out and about. At this point, it's just locally. We're trying to build it grassroots and get support from Houstonians, really telling the Houston story. But ultimately, we recognize and realize that there's a misperception about Houston from outsiders, that we know that it's a great place to do business, but a lot of folks don't realize it's a great place to live and to raise a family. So through the campaign in 2015 and 2016, we're going to launch it nationally to targeted markets. The ultimate goal from our perspective is to try to recruit talent to the region because we recognize that there's a shortage. And we're really trying to attract those folks in the STEM-related fields, folks just graduating from college and then maybe 1 to 3 years worth of experience in the workforce. So anyway, we're really excited about the campaign. There's a website if you would like to visit that. And I'm going to be out here. We're downstairs. We'd love to talk to you about Houston. I think a lot of you might be from Houston or live in Houston, but stop by and we'll just talk Houston.
Thank you very much. Yeah, it's really impressive the impact that they've made, and they have no paid media. So for everything you see that they've really gotten through, it's no paid media. I think that's amazing. All right, let's jump right in. So the panel we have right here after lunch is the ground view from public health and first responders. And Jeff Reisman is going to be our moderator. And he's with January Advisors. He's been there, he's had that firm since 2009. And just a few highlights that he's been doing for the last 6 months. The City of Houston passed an open data policy in September that he consulted on. He's currently working with the City of Houston's first comprehensive plan scheduled to be completed August 2015. He works on projects related to data analysis and government, and I know you've probably seen his name before in all the many projects that he's been involved with. He co-organizes the Houston's Civic Innovation Meetup. He's also been writing and syndicated by the Harvard Ash Center for Democratic Governance, Code for America, and Startup America. And he's also been named 2014 Rising Star by the Houston Women's League. So without further ado, I'm going to hand it over to Jeff Reisman. Thank you.
Thanks, Tracy. And thank you all for coming here tonight, or today. We're just going to have an informal conversation. There's a star-studded panel here, so I really don't want to take up a whole lot of airspace talking about things that I'm still learning about, digital health and first response. Maybe we can go down the line here and introduce ourselves. So, Michael, I'll start with you.
Sure. My name is Mike Gonzalez. I'm an emergency physician with Baylor College of Medicine, as well as the Houston Fire Department. So you can see I have my radio on, and I'm a little bit more casual than the rest of you because I'm actually on call today, believe it or not. But somebody else is covering, so I'm not going to run out of the room. So I'm a Rice alum, actually, and was in the military for almost 13 years before moving back to Houston. I love Houston, came back to Houston totally by choice, so for our GHP also. So the City of Houston, and really through a partnership with a lot of different people, is launching a very innovative new pre-hospital telemedicine project called Ethan, or Emergency Telehealth and Navigation. It is a widespread project that will have an impact on every single one of our citizens who calls 911, and that's why we got invited to the table. I'll talk a little bit more about it.
Peter Preziosi from Verizon. I'm at corporate and healthcare, and I guess a lot of you probably know about our backbone. You know about our HIPAA-enabled cloud, our secure networks, our work in cybersecurity. But as that whole marketplace starts to get more commoditized, what we need to be looking at as a carrier is how do we create greater brand attraction and stickiness to the Verizon backbone. So what I do is, from the healthcare perspective, look at it and see what we can do out in the marketplace to create innovative projects that will get consumers more engaged and the end users more engaged in our backbone. So, it's interesting to hear a lot of the comments this morning. I really believe that healthcare is highly personal. It's very local. And when the fit to come into a big company like a Verizon is kind of challenging because they want the next big billion-dollar idea. And, you know, in healthcare, it's a little bit difficult to do that because the regulatory challenges, the number of, the infrastructure and legislative issues that are already in place. How do you work into that? Craig talked about clinical workflow and integrating into clinical workflow. So you've got to really look at picking selective pilots. Here, we do that here both domestically and also globally. But look at how we can pick some pilots and look at how we can engage consumers around health technology adoption. We don't want to be like what happened with EHR adoption, where it took forever to get that adopted because they actually didn't take the end user into consideration. But, you know, really start to work in local communities to figure out how we could work on getting greater technology adoption to our backbone, and then consider how do we scale that up? How do we take that, you know, make it more scalable, and then move that around the country and as well around the globe?
So my name is Omar Matuk. I'm a pediatrician. Recently moved to Houston. I work for Legacy Community Health Services. It's one of the biggest federal qualified centers in Houston. We serve a lot of immigrant population, uninsured, underserved. My role there, besides being a pediatrician, is to help them create technology, another what they call mobile health technology, so we can address the needs of those of the population we have in Houston. I actually had a lot of experience back in my country, Mexico, working with a very big foundation called Carson Slim Foundation. And we reached out to several communities in the southern state of Chiapas, focusing on fetal maternal health. We partnered with the West Foundation back in California to monitor high-risk pregnancies. And part of what Peter was saying about partnering with a large network in Mexico, that the idea is to bring that, hopefully, innovation here into our very neat Houston population. Thank you for being here.
Awesome. So I'm going to ask you guys some questions about the individual projects that you're working on. I have different questions for each of you because they relate in different ways. And I'm hoping that we can keep the conversation centered around what opportunities exist for entrepreneurs here in Houston and how digital health entrepreneurs can approach organizations like yours to better pilot projects. So Michael, I think I'll start with you. You mentioned the Ethan Project. Maybe you can give a little more background about that, what it is, how it works, but also maybe a focus on how public-private partnerships are structured like that and how you recruit your community partners.
Sure, absolutely. So Ethan is really, it's innovative because all of us are familiar with 911, right? In fact, much of our community, not just here in the Houston area, but worldwide, lots of other countries have developed some form of emergency response. And in fact, we've learned that those numbers are going up exponentially across our community as well as our country. And so there is a need worldwide, and particularly in our city, growing as fast as we are, constantly adding more communities, more roads, more people, which is a good thing, right? We want Houston to grow. We can't keep pace with that. We're the second or third, depending on how you measure, largest fire department in the United States. And we have 94 fire stations growing all the time. We can't keep pace with whatever the number is, 1,000, 10,000 people a month or something like that. We just can't keep pace with that. No community could. So there is a growing need to sort of balance the convenience and availability of 911, which is a good thing. We want a community safety net. We want our citizens to be safe. We want our citizens to be able to get help when they need it. The downside of that is that we get people who call 911 because they stumbled on that step, and for a moment, we're a little bit uncomfortable walking. And that may or may not have been the actual person who stumbled who called 911. It could have been a bystander who was at their desk, who saw them sort of fall down, didn't know what happened, but called 911. Or it could have happened at a business where that business doesn't want to have anything to do with the medical liability of the issue and calls 911. We also see people call 911 because stuff went down the toilet, cat up a tree, all of those things. These are not made up examples. They happened like last month or last week or yesterday. Like this is a growing problem. To balance that, right, so that translates into more than 500,000 calls to 911 in the Houston area alone. 500,000 calls, growing all the time. So that translates into every time you call 911, you will get help. Someone will come help you, but that resource is limited. And so many people are surprised in the city of Houston that when you call 911, you get a fire truck. A fire truck. Not an ambulance, which is what most people expect. The good thing is that all of our firefighters are trained as emergency medical technicians. So they have the skill set to help you. If you call because you witnessed someone down in a true cardiac arrest, unresponsive patient who has no pulse, you will get a fire truck, a supervisor, an ambulance, maybe two. Like you get everything and possibly more than you could possibly have imagined to respond. But in between that and the stubbed toe, there's a lot of patients that may not need emergency medical care. So when you balance that with sort of our overcrowded, overused, underfunded emergency departments that we all know, I'm an emergency physician. I am good at what we do, and we are good at what we teach our physicians to do, but it is not efficient care, and we know that. But we take care of the people who come to us, regardless of their ability to pay, regardless of their insurance status, regardless of what the problem is. But for the patient, it's not necessarily an efficient use of their time, resources, or healthcare dollars. Triple the cost under our current system to get seen in the emergency department for something that may have been handled somewhere else. So what Ethan does for the first time is pair the emergency responders with a device, and I'm sorry I should have brought one with me, but we were doing training this morning and I actually used it for the training so it was dead. We're using a very commercial off-the-shelf device, a G1 Panasonic ToughPad. Many of you have seen that device or something like it, to essentially coordinate a secured, HIPAA-compliant, using our Verizon network, to just for the first responders in the field to allow the patient to speak directly to an emergency physician sitting at the 911 call center. That physician can then interact directly with the patient and decide quickly, because remember, this is what emergency physicians do every single day. Do you have an impending emergency, or is this something that can be handled in a primary care center? If it is, and we always want to keep patient safety at the utmost, in the forefront, that is our most important goal. But what if it is? That physician, thanks to our network of partners in the health department, around the city of Houston, including Legacy, I'm not sure Dr. Matupielza knew about that, but including Legacy, who we can refer these patients. So these clinics, these FQHCs, are giving us the ability, slots in their clinic scheduling time, valuable slots, we know that, but able to refer our patients over to FQHCs. So that does a couple of things, right? It saves the patient the emergency department wait time, which they are bound to have, an extended visit in the ER, and or a very costly visit in the ER, and matches them up with an FQHC partner who we hope, and at least from the data that we've started collecting, not only takes care of that acute medical need, but then matches them up and takes care of them in the long term as part of a medical home. Not only, so then we arrange this FQHC, but then we also partner with another program in the city of Houston called Care Houston. Care Houston is a health department program. The health department then has a series of healthcare navigators, social workers, needs workers who go and actually do an on-site, in the home, touch the patient and say, you know, what is the problem? Is it really because you didn't have a ride? Is it because you didn't know you were now eligible for Medicare? Is it because you don't have insurance? Are you aware of these different other programs that are in our community? So we have a unique opportunity in the city of Houston. This program is funded through an 1115 waiver as part of a federally funded program. But if we don't get this solution right, nobody's going to try it again for maybe 10 or 20 years.
Would you say that the problem is less about technology and more about the alignment of resources that already exist in the community?
It's a variety of things. So there's a significant lack of, there's a lot of siloing, as we know, in all sorts of industries, and healthcare is no different. It's amazing that, and it's a good thing, right, that we have this institution, the Texas Medical Center, which we all love and hold up with a, put on the altar. But at the same time, we also are the largest city that has the largest underserved and underinsured community in the U.S. Like, those two things shouldn't go together, yet they do. And so it's a variety of things. The technology are sort of the tools that we use. And I think a lot of the, at least some of the talks that I heard earlier and some of the, really the technology sort of needs to get out of the way, right? So the technology provides us the vehicle to give these necessary services, but it can't be about the technology. What has been very interesting in getting this program up and running is that the patients who, remember, were not told about this, we're not informed about this, we're not, have seamlessly transitioned over. Like they don't even bat an eye to the idea of an emergency responder putting a computer in front of them to have them talk to a physician. Like we thought we were gonna get a lot of, whoa, I don't know who this is, I don't know what, seamlessly, right? So if you put the technology in a way so that it works, so that it's not, there's no big hang up, there's no big, if you take the technology and utilize it in an efficient way, but don't necessarily make it the spotlight, things can go well.
I agree with that, but I also do think it is somewhat about the technology, because if you don't have, say, a physician on the other end feeling comfortable making that assessment using that video device, then it's not going to work. So I think that that's where I think so many people want to just jump so far ahead with these technologies, thinking that they can integrate that into their clinical workflows, but it does take a little bit of time for adoption. I mean, I think about that from like the answering machine to now it's completely onto your smart device, and you don't even use the answering machine or the GPS device that you can hook up into your car, and now we use Google Maps and Waze on our apps, on our smartphones. But you have to, it's sort of, it's a journey, you know, it's that whole, it's not necessarily the destination, and that's what we get excited about when we get involved in sponsoring these kinds of efforts at the local level. We actually did this particular project through the Clinton Foundation, their Health Matters Initiative, which is a domestic initiative. But that's one way that people get involved with us is, you know, we work alongside large nonprofits through the Verizon Foundation, but we also have a couple of other commercial ways to work with Verizon, and that's with we have a partner program. So we have a number of executives around the country that go out and actually hunt out new entrepreneurs and opportunities. Was there a...
Yes, I had a question
Yeah.
regarding Ethan. A great concept. I love it as a physician. I see a great need for it. You did mention very important point, the continuity of care by referring to the FQHCs. In the communities I serve, the wait time for those organizations can be up to a month. Are you all also partnering with private practitioners to perhaps avoid that and then looping back into emergency room by not getting primary care? And also the telemedicine laws requires either a face-to-face visit or a referring provider, or being actually utilized through a clinical setting, like you said, the first responder. Does that then qualify you all as that clinical telemedicine site? If not, how are you getting, how are you maintaining compliance?
Right. So even in a very simple terms, right, we specifically named the program because we're not doing telemedicine.
Okay.
We're not. Like, our providers, you're right, the law in Texas is very specific about what is required in order to really appropriately and safely practice telemedicine. So my physicians that work as part of the Ethan team are not prescribing medications. They are not, what they are doing is essentially advanced treatment, right? And trying to safely say, can we coordinate this care in a better way? So we're specifically not, treating, diagnosing, right? The second, or the first part of your question was really related to FQHC partners, and absolutely, the FQHCs that we've been dealing with, Legacy is one, there's 4 or 5 others, have been gracious enough to guarantee us same day or next day. Because really, we know that in spite of the fact that whatever the caller called for may not be a true medical emergency, there's some sort of perceived need, and we need to address that. Otherwise, they're going to call 911 again, and that's even worse for us, because now we've sent 2 crews out there. So the perceived need has to be addressed. So always, by definition, same day, next day. So we certainly know, and we have had discussions with different FQHC partners about, how to track volume and how to make those, we certainly are appreciative of every clinic appointment that we get, but we want to make sure that they're getting filled. So we actually have sort of a sliding window of time. So if it goes unfilled 2 hours prior to the scheduled appointment, it goes back to the FQHC, and then they can use it as a walk-in, they can use it however they want. So we've worked out different terms with different FQHCs, but in a way to guarantee that those appointments are acute, truly seen in the short term.
Can I just get back to,
Yeah.
so I just wanted to finish up, yeah, and I didn't mean to just jump right in, but I know that there's a number of entrepreneurs in the room, and a lot of people do ask us all the time, how do you work with Verizon, because it's such a big company. So I mentioned our Verizon Partner Program, and also we have our Verizon Ventures Group, so we're always looking at ways of acquiring those, promising innovations that are out there in the marketplace. And then we have a program through Ventures that I consult with and work on called the Powerful Answers Award, where we've given away, this is our second round. Last year we gave away $10 million, this year $6 million, to innovative companies that will ride on our network. And that money is given to you with nothing asked back in return other than we want you to ride off of our backbone. So it's your own IP. And it really does help, innovators in interesting ways. But also to put out a shout out to our sales teams. Without our sales team, a lot of times our sales teams will go out into the community and will actually work with groups like the City of Houston to experiment before they'll be willing to even make that purchase. I think that's interesting. And then we also have an innovation program, again, for entrepreneurs that want to get access to our APIs. They apply for that innovation program, and again, at no cost to them, they can work through our backbone to enable and scale up their programs at no cost to them.
Awesome. Yeah, I was going to follow up with that question, and I did want to also note that Verizon and other telecommunications providers are often the unsung heroes during disasters, and just having some type of communications backbone going at any given time during a hurricane, during a natural disaster, is pretty amazing. And the mere fact that entrepreneurs now have access to those kinds of network engineers and that kind of sophistication is pretty unbelievable. So if anybody's working in digital health and it does require some type of real-time communication, this is a tremendous opportunity to meet with Peter. So I'm glad you finished that thought. I was going to ask.
Yeah, no, so that's our big red program where we have, our big buses that will go out. We were a first responder to Hurricane Sandy. We were also, when those devastating tornadoes hit through Central America, we were out there with our cows, that's the cellular towers that will prop people back up. When the hospital was impacted by that, we had to prop them up immediately. So yeah, they're doing some really innovative things on the ground.
That's cool. On the thread of telemedicine, Omar, maybe you can talk a little bit about your work as kind of an in-person physician, but also some of your ventures in telemedicine and international telemedicine as it relates to wellness.
Yes. Actually, recently, we made partnership with a new startup that is focused on the uninsured and basically Hispanic population. And the name is like Healthy Advice. And they have a very interesting business model because they are doing the triage with licensed physicians in Mexico City. And it's a very cultural sensitive way to approach this population because instead of calling 911 and sometimes they have the idea that they might be deported and I don't want to do this, they speak to a doctor, they refer them to cash accepting clinic that usually are the FQHCs. So this whole idea of doing a triage, which they also have a video consultation, by legal status in the United States is not defined as a doctor-patient relationship. So they go around that, and they go around all the HIPAA, all the confidentiality. They only ask the patient the name, phone number, and that's it. And in that way, for people that are thinking in that market, which has a lot of political issues, but it's a reality in Houston. I don't know the recent numbers, but like 20% of our population has no insurance, and most of them are Hispanic origin. They don't have to be from Mexico, most are Central America, or we have some from Africa. But those type of ideas that innovate based on our current legal status in the medical, which is very restrictive, and offer a patient a solution and also access to care. As a primary care doctor, I see that a lot of consultations do not need to be, and probably Dr. Gonzalez sees that in the 911. A lot of them just need an advice. And luckily for us as a physicians, patients still trust what we said. I mean, hopefully that's still that way. But that's an idea you can think about. If you want to Google that, is in Spanish is consejo, advice, sano, like healthy.com. And I don't know, that was part of a group I advise. And they are not only in Houston, their target, of course, is all the 11 million or maybe 5, depending on what they decide in Congress with the law, people that won't have access to healthcare, regardless of the new reform. And their business model, either they partner with the organization or they charge the families, I think is like $50 a year or something like that for a family of 5. So it's a very low cost service. I don't know, I think that was a great idea to share with the group.
It's great.
How long have you been using that system?
They just launched on November 18th, so I actually have a talk to them tomorrow to be honest. We're partnering, making the final arrangements, because we also don't want we don't want them to charge the patients,
Right.
and we also don't want to.
It's a great approach, very creative.
But I think it's, and the doctors are very well trained. And actually this call center has been running for 20 years, so they know what they're doing.
Excellent, very good.
I was going to say that there's an interesting disruptive model that's coming out. The guy that started Uber is now starting a company called Pager. I don't know if any of you have heard of it.
Yes.
The chief medical officer of Teladoc went over there to help him to start Pager up.
Boxer.
And yeah,
Boxer.
right. And I think that's really interesting because when listening to the hospital team this morning, nobody was mentioning, we had a discussion off to the side about retail health and what the impact that will have on business models in the hospital market. I just came from the mHealth Summit, and the chief medical officer of Walgreens announced their partnership with MD Live, which is a Teladoc-like service. And if you think about the wraparound of products and offerings that the consumer health market's going to have, and the play that's going to be in there when Walmart steps in, and our hospitals give so much credence to their buildings. We're going to have to really think about what the impact virtual care is going to have. Now, obviously, we're going to still need hospitals into the future, but are we going to still need these big, huge, large infrastructures? So I think that that's something to take into consideration, and it does fit into sort of that first responder because it's that feeder system and how that's going to ultimately look.
And we're starting to see that shift of basic healthcare moving from doctor's offices and hospitals to CVS and Randall's and supermarkets. I'm not afraid to admit that I get my vaccinations and flu shots from the supermarket. It's one of those things where as the retail industry shifts to accommodate that, it's going to create more opportunities in telemedicine because there's going to have to be experts be piped into that floor. I'd like to open it up for questions for anything that we've discussed here today so far.
Mr. Presidency, you mentioned a lot of great programs for entrepreneurs partnering with Verizon. Do we just go to your website to learn more about that, or are there specific avenues to get additional information? And second question is Verizon healthcare strategist. A lot of the individuals on the panels have mentioned before we have the technology here, we have the ideas, but as far as implementation, the education and getting physicians to adopt it isn't really there. Outside of technology, do you see that as an area that Verizon could potentially move in?
I think, Shamar is raising his hand. I mean, I did not unfortunately bring the website addresses, but we can certainly get those out to everybody in the room for the partner program and the innovation program. And but the other, I agree. I think that physicians, particularly amongst all clinicians, are key in terms of adoption. And look what happened with Google and Microsoft when they tried to launch their personal health record applications. And if you're not getting clinicians to buy into that and use that, and it gets back to some of the earlier points this morning, if it doesn't fit into a clinician's workflow, they're not going to be interested. However, having said that, as we move toward greater patient-centric models of care delivery, And if there's greater out-of-pocket cost of that consumer, there's going to be greater demands placed onto the system. And I think that there's going to be more of a drive from what the consumer wants. There was a really good article just out recently around Generation C, that connected, highly engaged consumer that is a digital native now. And if you take a look at, how attached we all are, what it's estimated, we look at our smartphones like greater than 100 times a day. So I think that there may be changes that will occur. I'm not suggesting it's going to happen overnight. I don't believe in the overpromise and the hype of health IT, but I do think that that's going to certainly make some inroads into the changes that will require physicians and other clinicians to really change their behaviors.
Can I comment just briefly on that? So I think, particularly related to the EMR and what your phrase, I think exactly was sort of what consumers want, and particularly the disconnect. So all of us that are clinicians use an EMR daily, but it really, the patients from their side, and many of you are patients yourselves, right? They think it's all connected already. And so in many ways, like, we have failed to deliver what we promised 20 years ago as a healthcare system. Like, they think it's possible. They come to the ER and they literally say, like, well, look it up. And
there's somebody on a bus.
great, I would love to be able to do that. And so for many in the room, it's not the technology. That one of the people in here mentioned during a previous discussion, that's what the health information exchanges are. Those connections exist already, and they exist in our town. The reasons they don't work are decisions by human beings. They don't work because the connections are not allowed to be made. That is a huge thing. We have failed to serve our public in an important way, but that is not a technology failure. That is a decision maker failure. And we are not sharing the information that we can. There are literally connections that are this close to being done, and all we need to do is take that out. And we could have the exchange that we talk about, that was talked about 20 years ago, but we have not made in practice, not because it doesn't exist, but because we have refused to let it work. And it is extremely frustrating because on the pre-hospital or emergency care setting, me having access to something that you, in your record, is huge, because it could mean the difference between you getting a potentially complicated procedure that is unnecessary. But if I can't access it and read the report or sometimes see the image, we may end up spending a hospital stay or thousands or tens of thousands of dollars for no good reason.
And the financial incentives and the regulatory environment, I think, Scott, you mentioned it before about the wearables market. It's not going to see the light of day if there aren't the real incentives, if it doesn't integrate into clinical workflows in the proper and relevant way, if it's not relevant to people's lifestyle. There's a whole host of things, but I think we're going to see a lot more shifts into the future after we see a few big ideas really take hold.